Hello, everyone, and welcome back to our Infection Prevention and Control podcast, IPC In Action. This is our February 2024 edition. So, I'm Fran, I'm one of the Infection Prevention and Control nurses.
Hi everyone, thanks for listening. I'm Jen, I'm one of the other infection prevention and control nurses.
So, we're going to do something slightly different today. Obviously, still along the lines of IPC.
Of course.
Of course, obviously. In that we're going to be running through the A to Z of isolation. So effectively what we're going to do is we've got, obviously, I'm sure a lot of people know about our contact precautions and airborne, droplet, the different modes of transmission. So we're going to run through the priorities for each of those.
And we've split them down into the two groups of sort of contact precautions, and then we will cover the sort of airborne and droplet precautions and the sort of different organisms that fall into those groups.
Yeah, absolutely. So this list that we've come up with, obviously it is a lot of information to take on, and all of this information is available on the intranet as well. We do have a very helpful document, which is called Routes of Transmission, Isolation Priority and Infection Control Precautions.
Bit of a mouthful.
Yeah, but a very, very handy document if you're able to print one out and have one on the ward.
Yeah.
So we would definitely recommend.
Absolutely, it is really helpful. It's
Yeah.
got like your isolation priorities and your infectious period. There's loads of helpful information,
Really
and it's
helpful.
arranged in an A to Z, so it's also easy to find your organism.
Yeah, exactly.
Another place to access sort of more resources is the National IPC Manual.
Yeah.
The English National IPC Manual. Scotland has a very, very good one that's actually complete.
Yes.
Ours is still a few chapters behind, but we're getting there. And they also have an A to Z. It's which is also a very helpful document and available on the internet.
So, yeah, this list it includes the following, but it's not exhaustive. So any queries you have about anything that might be a bit more rogue as such, or
Yeah, like
not
for instance, any sort of
heard
tropical diseases that
Yeah.
we might not see as often,
Yeah.
we haven't included them. We've wanted to go with the list that's your
Yeah.
more common, like more likely to see organisms.
Yeah, so please contact us if you have any queries about absolutely anything else. So, we're going to start off with contact, so the contact route of transmission. So, just as a summary for contact precautions, obviously we're wanting to be wearing gloves, aprons, obviously emphasising good hand hygiene. The only other instances where you may want to kind of add on more things or change them is, for example, with carbapenemas producing enterobacteriales, or
Nice,
CPE, then we want to be wearing long sleeve gowns, and things like norovirus, then we want to be wearing a surgical mask if there's any vomiting. But yes, we'll just go through
The list. Yeah, not sort of, it is
It
A
is
to Z to try to keep it relatively simple and easy to understand. So starting off, our first one we've got on the list is Campylobacter. Now, Campylobacter is an organism that causes diarrhea. It's normally caused by food poisoning, so poorly cooked or poorly handled raw meats, like predominantly chicken. So yeah, Campylobacter, we get a lot of it in the summer in sort of barbecue season.
Yeah.
So it is something that we need to isolate. It's one of those sort of enteric organisms that we need to isolate until they're 48 hours symptom-free. And it's excreted in the feces. And if they don't have ensuite facilities, then they need to have a dedicated commode, please.
So moving on to, as I'm not going to say the long word again, but CPE. So if your patient is known or suspected CPE, then they need to ideally be isolated for they do need to be isolated for the whole of their admission. Once colonised, they continue to be an infection risk, so it is very important that they remain isolated. If there's anywhere, like in the patient note section on EPR, that can be documented, so it's carried on if they were to move wards.
Yeah, and they have an alert on EPR as well for any CPE suspected or positive individuals. Group A strep is our next one. So the full sort of name of the organism is Streptococcus, but it's normally shortened to Group A strep. Can be a common cause of cellulitis. So with Group A strep, we need to isolate until 24 hours of appropriate antibiotics have been completed. So appropriate antibiotics, as in antibiotics that the organism is sensitive to. So sometimes they are more resistant than others. So it just needs to be that clinical decision made. Sometimes a discussion with micro to make sure that those antimicrobials are in fact going to kill the group A strep.
Moving on to the one and only C. diff. So with C. diff, they need to be isolated until they are 48 hours free of loose stool and evidence of a formed stool. They need to have a dedicated commode or a side room, and this needs to be, we need to be making sure that it's cleaned daily, that red wipes are being used in the room. So it's really important they are isolated away from other patients due to the spore-producing nature of diarrhea.
Diarrhea of unknown origin is next on our list. So things like gastroenteritis, we don't always know exactly what is causing a patient's diarrhea, but with the other diarrhea type illnesses that we've mentioned, again, they need to be isolated until they're 48 hours symptom free.
ESBL. So if if it's known or suspected that your patient has an ESBL, they need to be isolated for the whole of the admission, and this continues to be an infection risk.
Yeah, our sort of multi-drug resistant organisms, we definitely want them isolated, and ESBL would fall under that multi-drug resistant organism category. GRE is, again, another example of a multi-drug resistant organism. It's resistant to a family of antibiotics called glycopeptides. It does depend on the location of infection, but definitely in areas like hematology oncology, that's an absolute must that they are isolated. And in hematology oncology, it would also require that heightened level of cleaning, which would be a red clean when that room is vacated. In all other areas, it would just be your sort of standard amber clean, but GREs need isolating, please. I don't think there's one that we're going to talk about that doesn't need isolating.
No,
but
no, I mean, it's pretty much all isolation. So moving on to hepatitis A. So hepatitis A needs to be isolated due to its maximum infectivity being immediately before and for 10 days after the onset of first symptoms. They also need to have a dedicated commode or an ensuite.
So there are a whole bunch of hepatitis viruses. The only ones that we have put on this list are A, as Fran's already mentioned, and E. So hepatitis E, maximum infectivity is immediately before and for 14 days after the onset of first symptoms. And it's another enteric one. Dedicated commode or ensuite facilities are needed.
And herpes. So herpes, it's dependent on the area, as a virus can shed for several weeks. So if you've got, say, herpes simplex, so cold sores, hepatic whitlows, because of it shedding for several weeks, then we need to just assess the individual risk, and you can discuss with us as well as to how much of a risk it's going to be if they're left in a bay or whether they're going to a side room.
A bit of an individualised risk assessment probably needed for herpes, really, isn't it? Impetigo, so quite a common childhood infection that they sort of typically get these sores on their faces. While those lesions are discharging fluid, you need to isolate until they have completed 24 hours of appropriate antibiotics. Again, similar to sort of group A strep, because I think impetigo is actually caused by streptococcus. So moving on, we have invasive group A strep. Now this one made the news quite recently with causing there was a lot of pediatric cases of invasive group A strep. It can also cause necrotizing fasciitis. These ones do need liaising with IPC and micro. Micro is for this to make sure that they're on the most appropriate antimicrobial coverage, because it would be an extended period of antibiotics that they would require to treat the neck fash, and it again needs isolating.
There's no kind of specific length of time for isolation, so that's why there's discussions needing to be had.
And I think just because it can be that little bit trickier to treat, but and it would need to be another risk assessment taking place with IPC and micro.
MRSA. So with MRSA, depending on whether they're colonised or infected, ideally they need to be isolated for the whole of their admission. If, for example, you know that you've got an MRSA infection in sputum or in an open leaking wound, that is a high priority for isolation. Everybody obviously needs to be on their decolonisation, so it's always going to be a high priority, and we'll contact you if there are any readmissions of MRSA as well. Hopefully then we can get them into a side room.
What we are sometimes sort of forced to do due to a lack of isolation facilities is to make that risk assessment that if the patient is colonised with it in nose and groin but they don't have any wounds, and they have received their decolonisation, sorry, we will sometimes make that decision to have them put in the bay because we need to isolate a higher priority, more infectious patient. But ideally, as Fran said, they do need to be isolated for the whole of admission. Norovirus, our friendly winter vomiting bug. Again, another one with diarrhea and vomiting. They need to isolate until 48 hours clear of symptoms. If somebody's vomiting, it is that much easier for those particles to become aerosolized. So it's not mandatory at all. It's just advised. I would wear a surgical mask just to keep yourself safe and prevent the chance of you getting norovirus.
Yes. Rotavirus as well. So this is shed in feces for up to 8 days after the onset of symptoms. So again, using a dedicated commode or an ensuite is ideal, and making sure that they're being cleaned daily as well if they're going to be in the room.
Salmonella can be excreted in the feces for several weeks. Another one to isolate until 48 hours symptom-free, and typically a sort of food poisoning related bug.
So scabies. So this is classical and Norwegian scabies. So classical, they need to be isolated until 24 hours after appropriate treatment, and Norwegian scabies, they need to be isolated until the course of treatment has been completed. So usually these will be identified by dermatology.
And the final one in contact precautions is shingles. So if the lesions are in an area, for instance, on the trunk of the body that can be covered by loose clothing, then it is generally okay for them to remain in the bay. If they have ophthalmic shingles, if it's in their eyes, if you're in a setting such as haematology oncology, if the individual is immunocompromised, or if you're in maternity, they then require isolation at that point. And that isolation period is from the onset of lesions until 7 days after they've appeared.
So that was contact. That was contact. So
that was a big list.
Just actually something I was thinking of, just as a side note, as we said, this is an A to Z. This is not our order of priority. Just to emphasise that we're just telling you them in an A to Z.
Just an A to Z organism list.
Yes, exactly. If you have any queries about the priorities for isolation, please contact us and we will discuss it.
I think in the contact list, just as a very quick aside, CPE would probably be top. C. diff is a high priority. They're all quite high, unfortunately.
And there are quite a lot of them.
And there's quite a lot of them. So, if there is any confusion, please give us a shout, because it can be hard to sort of make that risk assessment of which is the highest priority. And sometimes we do have to make those slightly tricky decisions. So airborne / droplet.
So obviously they're two different things, but we're just going to do a bit of a mix because they can be very similar in their transmission.
And there's always a little bit of controversy around the sort of airborne droplet. So we've lumped them together for the sake of ease of understanding.
Do you want to kick us off?
Sure. Chickenpox is our first one. So chickenpox is airborne. The infectivity of it is 2 days before the onset of rash until 5 days after the lesions first appear and all of those spots or vesicles have crusted over. Only those with a known history of chickenpox, so they know they've either had it as a child or they've had their vaccine, should be taking care of these individuals. Our favourite coming up next.
Our favourite, the
big
star
C.
of the show. Or not at the moment, actually.
No.
I mean, well, So COVID-19. So obviously the patient needs to be minimised. What's the word? Isolated for a minimum of 5 days after onset. So on this day 5, we need to check if all of their symptoms have resolved. And for immunocompromised patients, they need to be isolated for a minimum of 15 days and then retested. If they've got a minor cough by the end of it, that's fine. We just want to make sure things like temperature, runny nose, that they've all gone before they are de-isolated.
Absolutely. And the way we're counting the days is the day of the swab or the date the symptoms started. That is day 1, and you can then count up to 5 days from there.
Yes.
Okay, next is influenza. So slightly different from COVID. We need to isolate for a minimum of 5 days plus 48 hours. So an individual's symptoms need to have resolved and have that 48-hour sort of buffer to know that they are definitely had that resolution of symptoms to sort of then class them as flu recovered.
Right, talk of the town. Measles.
Yes.
So measles, they need to be isolated until 4 days after the onset of rash. So that is including the day that the rash started. So this needs to be a single room with an ensuite. Ideally, we don't want them to be leaving their room to go to the toilet elsewhere.
No, they need a dedicated commode. If there is no
exactly.
ensuite facilities,
Yes.
they can't leave the room.
Yeah. Again, if you have any queries with step downs, if you've had a patient, say, with measles in a side room, please contact us and we can always go through it and assess it with our infection control doctors as well.
Meningitis. So you do have either viral meningitis or bacterial meningitis. We tend to get a lot more het up about bacterial.
Yes.
So if somebody has bacterial meningitis, they need to be isolated in an ensuite single room, and really that would be until completion of treatment. So it would be on discussion with micro and IPC to pull that individual out of isolation, as it would just have some sort of implications. So we'd need to make sure that we weren't doing it too soon.
Mumps. So with mumps, due to it being a droplet and direct contact with saliva, so they need the infectivity period is 5 days before the symptoms appear, but also up to 9 days afterwards. They need to be isolated for 10 days after parotid swelling appears.
Yeah, you end up getting that like sort of chipmunk look around the sides of your, just underneath your jaw where those parotid glands are, and it does look very painful.
Yeah, absolutely.
Monkeypox. So we haven't seen this bad boy in a little while. Hopefully it's not going to make a resurgence anytime soon. So monkeypox needs to be isolated until all lesions have crusted over.
Yes, and moving on to RSV, so respiratory syncytial virus. I just like saying the word syncytial, to be honest. So it needs to be isolated up to 7 days after onset. There is also the risk of prolonged shedding in immunocompromised patients. So again, assessing the risk before they are moved out of the side room.
So other respiratory viruses that we do tend to see, such as adenovirus, rhinovirus, and parainfluenza, those we want to treat in a similar manner to RSV, with those up to 7 days after onset. Some people will be recovered in less time, but if there's any sort of query, like you're really needing that isolation room for somebody else, for instance, and it's still under 7 days, give us a shout.
Moving on to, we're coming up with two types of tuberculosis. So starting off with pulmonary tuberculosis. So they need to be isolated in a side room until a minimum of 2 weeks post anti-TB chemotherapy. Again, this can be discussed with us, the patient's doctor, our infection control doctors, and we need to, again, assess the individual risk before they are coming out of the side room.
Yeah. The sort of caveats to TB is you can get multi-drug resistant or extensively drug-resistant TB. These are quite a sort of significant public health concern. So these would need to be in a negative pressure side room, of which
we don't have any in the trust. The only place that there is a negative pressure side room is in ED in Gloucester, so that is obviously a bit of an issue. But if that were to occur, then we need to potentially look at prioritising them for isolation in negative pressure side room elsewhere. But we would obviously get to that if it came to it.
And our final one on the list for airborne droplet precautions is whooping cough, so also known as pertussis. Well, pertussis is its proper name. It's called whooping cough because children tend to make this sort of classical whoop sound when they cough. So the isolation period is up to 3 weeks after onset of these paroxysms, and it's these sort of fits of coughing or these paroxysms that cause that whooping sound, or 5 days after the start of appropriate antibiotics.
So big old rundown, and I realised when we started the airborne and droplet we didn't cover the precautions. Yes.
Right.
So airborne and droplet, I mean, again, it's assessing the risk of each individual one. I might be wrong, please correct me. I would probably say in a lot of these airborne and droplet viruses that an FFP3 is required a lot of the time.
I think with the exception perhaps of RSV and your other less severe respiratory viruses like adenovirus and rhinovirus, I think with the exception of those, all the rest of them, you would want an FFP3 mask and then risk assess that visor.
Yes.
Now with measles, just measles, and any MDR-TB or XDR-TB, which is that extensively drug-resistant, you would also need a visor.
Yeah.
All of the others, you can just risk assess if that visor is needed, if there's a high risk of splashing into your sort of eyes, which are another mucous membrane, not to forget.
Also considering that with a lot of these for direct patient contact, you may also need to be wearing an apron and gloves as well. So again, please risk assess for that. As we said, all of this information is available on a very handy document, so I'm sure we could include a link to it actually, to be honest, because it's very handy to be able to refer back to.
We can pop a link when we send this out in the comms.
But hopefully this has been a bit of an informative kind of break from the ordinary, just us talking about one organism kind of podcast. And
we do really appreciate the difficulty in our lack of isolation facilities and making those difficult choices of who to isolate and who to pull out. So we are always here if you need any help making those decisions, and micro are always available overnight. So please don't forget to give us a shout if you need any advice or a bit extra support to help make those decisions.
Yeah. So we hope you've enjoyed listening to this, and we hope that it's been useful for anybody that is listening. As Jen said, please don't hesitate to contact us if you need us. We're on extension 6122 for Gloucester and extension 3129 for Cheltenham. We have our email address. Please let us know if you have any ideas for further podcasts, anything you would like to hear. We're very happy to take those on board. We have our newsletter coming out in March. A whole range of things going on. So, we will see you in March.
Thanks very much. Thanks for listening. Bye.